Hey everybody, welcome back to another live stream from Synapse Care Solutions. This month we are going to focus on IVH Prevention and Care. It is my pleasure to introduce our first presenter for this month, Diane Wilson. She is a neonatal nurse practitioner specializing in neurocritical care in the NICU at Sick Kids in Toronto. I thought doing Diane's presentation first would be great because she goes through a review of IVH pathophysiology, risk factors, and then just some of our common knowledge around outcomes for babies who have IVH. Then she dives into a quality improvement and research project that they did at her hospital looking at when they intervene on babies who do have high-grade IVH and ventricular dilatation. Then she talks about the outcomes for those babies after they implemented this program. I know that you're going to really enjoy this presentation. It shows how we can use examples of best practices from all over the world to help us guide the care we provide for babies and to really improve the way we do care. If you want to get the resources, the slides, and any of the other references that Diane mentions during this presentation, go ahead and either click the link in the show notes below or scan the QR code right on the screen, and you'll be taken to a page where you can enter your email address, and then you can get all of the resources and the replays and reminders every single week. If you haven't already, go ahead and hit that like and subscribe button. It really helps us out a lot. It helps YouTube to know that you like videos like this from us and helps us to bring you more free content. So without further ado, I'd like to introduce Diane Wilson from our One conference in 2020 that happened live in Orlando. I know that you're going to enjoy this replay, and I hope to see you at the end.
What I really want to talk to you about is post-hemorrhagic ventricular dilatation and hydrocephalus. That is something that we have in the past wondered what to do about, and we have been confused sometimes about how long to wait before intervening for those babies that have PHVD. And I'm going to show you some evidence today that supports a very early intervention approach for these babies. These are my objectives. I'm going to quickly run through the IVH stuff because I do want to get to the PHVD slides at the end, which I think are probably the most compelling. I need to thank Dr. Lara Leister, who is a neonatologist from the Netherlands and worked very closely with Dr. Linda de Vries, who really is the grandmother. I would say Joe Volpe is probably the grandfather of neonatal neurology, and I would say that Linda de Vries would be the grandmother of neonatal neurology. She really has taught me a lot and certainly has mentored many fellows in her program, and she's come over to Sick Kids on several occasions now and has taught us really a lot about how to read head ultrasound, a lot about how to intervene early for tiny babies that have IVH and PHVD. And a lot of times we've thought in the past, okay, you have a grade 3, grade 4 IVH, there's nothing we can do about that anymore, and your outcome is not going to be as good as what it would have been if you only had a grade 1 or 2 IVH. But now we know differently. And I've always been one of those NICU nurses. Everybody has their niche in NICU, and I've always been one of those NICU nurses that loved the term baby. I didn't want to look after preterm babies. I'd happily give those off to my colleagues, and I would be the one that wanted to look after the big, robust IDM babies or the babies with HIE or the babies with pulmonary hypertension. And I've changed my thought process. It's been a long road, and this is my 30th year in nursing. And I really have changed, and I do believe now that the preterm baby who has grade 3 or 4 IVH, we can do something about that. So I'm going to show you that now. But let's start off just by making sure you're awake, and I'm going to ask you a few questions about IVH. So in preterm babies, what is generally the source of bleeding in IVH? Just call it out. Germinal matrix. So you can see the germinal matrix here. So when does the germinal matrix mature? 32? Yes, 32 weeks. Very good. Okay, so the suggested mechanisms for injury really are because the germinal matrix is immature and fragile. Then there's fluctuations in cerebral blood flow. Can you name some factors that are implicated in cerebral blood flow fluctuation that can lead to IVH? We talked about this the other day. A lot of anything really that can change abruptly cerebral blood flow. So rapid fluid boluses, need for intubation and ventilation, any kind of noxious stimuli, neonatal transport, hypo or hypercarbia, and anemia, all kinds of different things. How about, these are medical interventions. Now we've heard a lot about brain care bundles, but this question is referring more to medical interventions. Could you name 3 medical interventions that have shown to decrease the incidence of IVH in preterm babies? Okay, I'm hearing lots of different things. antenatal steroids, prophylactic endo, delayed cord clamping. So some of these are a little bit controversial, but for the most part, these are the interventions that we can do. Mag sulfate should be in there as well. That could potentially decrease the risk of IVH in a preterm baby. We know that with increasing gestational age, your chance of IVH or the incidence of IVH is reduced. So this is data from the Canadian Neonatal Network that really is just showing us that with gestational age, the incidence of IVH increases in germinal matrix hemorrhage, intraventricular hemorrhage, and interparenchymal hemorrhage. So when we think about the epidemiology of IVH, term babies can also develop IVH, and in term babies, it's mostly related to trauma that happens during the delivery or in utero. It could be because of a coagulation anomaly. Most commonly, it's due to sinovenous thrombosis. And now we're learning more about genetics, and there is actually a role of gene mutations in causing interventricular hemorrhage that happens in utero, and we're seeing these more often now that we know what genes to test for. So COL4A1 and COL4A2 are genes that are associated with collagen disorders that can cause bleeding in the brain in utero. So about 30% of term babies with IVH have sinovenous thrombosis. So in terms of timing of IVH, when is IVH most likely to occur in the preterm baby? A, B, C, or D? A, yes. 90% occur by day 3 of life, 50% on the first day of life, 25% on the second day of life, and 15% on the third day of life. 20 to 40% of those babies will have progression of hemorrhage over 3 to 5 days. The majority of those babies are clinically asymptomatic and are only detected by routine head ultrasound screening. There are some clinical symptoms that we can look for, like irritability, drops in hemoglobin. We could use NIRS or AEG monitoring, as we just heard about, and very rarely will you see signs of increased intracranial pressure. So head ultrasound is the key modality we use to look for IVH in preterm babies, and we do that serially to look for changes in the IVH over the first few days of life. Usually we start on day 3, and then we'll do another head ultrasound on day 7. We use MRI to look for associated lesions, as more of a longer-term screening tool. So we all know about Papille and later adapted by Volpe's classifications of IVH. So there's grades 1 to 4. We don't really use the term grade 4 IVH anymore. Now we describe more the periventricular hemorrhagic infarction that we're seeing. So we say a grade 3 IVH with periventricular hemorrhagic infarction or with ventriculomegaly. So ventricular dilatation is putting the white matter of the brain at risk, and I'm just going to show you a little pictograph of what that might look like. Germinal matrix hemorrhage might look just like a little dot of blood in the ventricle here. Grade 2 IVH is partially filling the ventricle but not causing any dilatation of the ventricle. A grade 3 IVH is when you start to see dilatation of the ventricle, so you're seeing pressure onto the vulnerable white matter of the brain here. And then grade 4 IVH is often this fan-shaped hemorrhagic infarction that is bleeding into the white matter of the brain. These are some ultrasound images showing you what IVH might look like on ultrasound. So on the first image here, you see a tiny germinal matrix hemorrhage, this tiny little dot of injury. Grade 2 IVH, blood within the ventricles here. Grade 3 IVH, you're starting to see that ballooning of the ventricle out. And grade 4 IVH, you're seeing bleeding into the white matter of the brain. So the complications of germinal matrix hemorrhage, of course, there is periventricular hemorrhagic infarction, so when there is a rupture into the white matter, and then, of course, post-hemorrhagic ventricular dilatation. So all of this pressure on the white matter is detrimental to these babies' long-term outcomes. Periventricular hemorrhagic infarction happens in about 6% of preterm babies. It's caused by venous congestion and pressure. It can happen unilaterally or bilaterally, and imaging, certainly the desired modality of imaging is ultrasound, as I've already said, but MRI will provide the details of the injury over time. So here on these pictures on the right-hand side, you can see an ultrasound image at the top with the periventricular hemorrhagic infarction in this fan-shaped distribution. And then here on the MRI image, you're seeing more of a delineation with cysts already starting to form there. Here's a picture over time of what the MRI might look like in a baby that's had a periventricular hemorrhagic infarction, where there was this bleeding into the white matter. There's now a porencephalic cyst that has taken over the space where that white matter was. So the outcome of IVH really depends on the effects of those toxins and free radicals that have been floating around in that blood that's sitting in the ventricle and how much irritation that's caused to the white matter. It also depends on the size of the IVH, the location of the injury, and whether there's been hydrocephalus and the need for VP shunting. In terms of neurodevelopmental outcome, we know that babies that have had periventricular hemorrhagic infarction are at risk of severe neurodevelopmental delays. And in this study, where they looked at cerebellar volumes, and they noted that even babies that had periventricular hemorrhagic infarction that was nowhere near the cerebellum, their cerebellar growth was much smaller. In terms of outcomes of IVH, so we know that grade 1 and 2 IVH generally have normal neurodevelopmental outcomes, but grade 3 and 4 are at high risk of motor and cognitive difficulties, and this chart really just delineates that. This is an MRI here showing how a large IVH is associated with ipsilateral, cerebral, and contralateral cerebellar volume loss. Even though the IVH was happening on this side of the brain here, and you can see that's where the porencephalic cyst is developed, there's also reduction in white matter volume on the other side and cerebellar volume on the contralateral side. We know that the location of the injury delineates the long-term outcome of what will be affected in the patient, and you can see in this pictograph here that if the IVH is happening in this area, then the knees, trunks, shoulders, and further out, moving up, different areas are affected. So what is the classic motor impairment in bilateral grade 3 IVH? Both sides. Damage to the white matter on both sides. Anybody know the answer to this question? So it would be spastic diplegia, so affecting both sides. And then large unilateral periventricular IVH can lead to a hemiplegia, so only affecting one side. Okay, so let's move on to PHVD. So 30 to 50% of infants with IVH, with large IVH, develop PHVD. Usually starts to happen in the second week of life after a large IVH or periventricular hemorrhagic infarction. And what the definition really of PHVD is when the ventricular size is greater than the 97th percentile. And I'm going to show you some charts of how we measure ventricular dilatation. So it's usually due to impaired CSF flow or a clot that occurs either in the aqueduct, or it could be due to impaired CSF reabsorption because of tiny clots that are floating around, proteins and little fibrosis that are happening in the ventricular system. It's usually silent until there are signs of increased intracranial pressure. But what we've learned is that if we intervene early, we can prevent those signs of increased intracranial pressure and hopefully preserve some of that white matter. So serial head ultrasound is the modality that we use to look at IVH over time. And we usually do our head ultrasounds beginning on day 3 of life, and then we'll follow up with an ultrasound on day 7 of life. If there are measurements that are taken, which I'll show you in more detail in a moment, that show that the ventricles are dilated beyond a certain point, then we'll continue to do head ultrasounds on a bi-weekly basis, measuring the size of the ventricles. So these are charts that were developed by Levine and Davies. On the left side of the slide here, you'll see the Levine index of ventricular dilatation. So in this index, what we would do is plot the ventricular index, which is the widest part of the ventricle. You can see in this tiny picture up here, the widest part of the ventricle from the fox to where the ventricle is ballooned out to. And we would plot that measurement on this Levine index here. And when we start to worry is when the ventricular index is above the 97th percentile. So this would be the mean ventricular index, and then this would be the 97th percentile. So if the ventricular index is in this gray zone, we're worried about dilatation, okay? And that's when we would start doing our serial head ultrasounds twice a week. Over here is the Davies diagram just showing you whether there's mild, moderate, or severe dilatation of the ventricle, and that's based on the anterior horn width, or just the widest part of the ventricle, period, not from the Fox. So in terms of prevention of PHVD, we want to prevent prolonged pressure on that vulnerable white matter. And about 35 to 40% of infants will need intervention, and I'm going to show you some of our results that will actually bring that home. So it can be complicated by blood and high protein levels, and there's also, of course, the weight of the infant and instability of the infant. There's lots of complications that can happen, like infection, over-drainage, potentially need for revisions. If you're putting in VP shunts, you can have skin lesions or skin breakdown over the area of the shunt. So there's many different complications that can occur. And there's many different management strategies that have happened over the years. Third ventriculostomy is one thing, choroid plexus fibrinolytic agents have been used in the past, diuretics or other agents. There's different types of shunts that can be inserted, subgaleal shunts, and so on. But our current practice is to start with serial lumbar punctures and then potentially place a reservoir and then hopefully avoid needing a shunt in the long run. I'm going to show you why we started to do that, because we had at Sick Kids in Toronto always been a very late intervention site until about 2 years ago. There'd been no consensus by especially our neurosurgeons on when or why or how to intervene, and there certainly had been no RCTs on whether to treat or not to treat PHVD. And then we had Dr. DeVries come over, and she was just visiting and doing some research with Dr. Stephen Miller, and she was looking at our PHVD patients and what we were doing in terms of intervening for those patients. And what she noticed, of course, is that we were, as I said, very late interveners for these patients. So we didn't intervene for post-hemorrhagic ventricular dilatation at our center historically until there were signs of increased ICP. Bradys, DSATs, poor feeding, vomiting, all of those kind of things. And at that point, our neurosurgeons would be convinced, okay, maybe it's time that I need to do something about this. And where Dr. DeVries came from, she had always had an early intervention approach for these patients. And in her early intervention approach, she used the Levine index, monitored the baby's head circumference based on those charts that I just showed you. And when the ventricular index was greater than 2 standard deviations plus 4 millimeters, she would start to intervene early. And she taught her group to do this. And they would do 2 to 3 serial lumbar punctures with the goal of removing 10 mils per kilo of CSF at each puncture. And then they would continue to monitor the head ultrasounds and look for dilatation of the ventricles. If they remained dilated after that, they would put in a reservoir, which is just a tiny little dome-shaped shunt that has a little tube on it that goes into the ventricle system. So it sits just under the skin and can be tapped on a daily basis to remove the 10 mils per kilo of CSF. She'd do that for a number of weeks, and if there was improvement in the ventricular size, then she would stop doing that and continue to monitor the head ultrasounds. And certainly if there was progression, she would continue to do that until the babies were big enough to have a VP shunt inserted. When Laura came over to Sick Kids in Toronto to do her neonatal neurology fellowship, part of her research was to look at our cohort of patients who had been late interveners and compare that to the cohort of patients in the Netherlands from Dr. DeVries' unit. And she found some remarkable results. What she showed was this is the early approach group. EA is the early approach group, and LA is our group, the late approach group. In her early approach group, there were 114 babies, and in our late approach group, there were 79 babies. And they all went down this various pathway, and some got a shunt and some did not. And certainly in her group, the majority of patients had a lumbar puncture as their first treatment. And Many patients avoided having a VP shunt, and I'll show you the absolute numbers in a moment. In our group, 7 patients got lumbar punctures, and many went on to receive VP shunts. But what was really striking were these results here. In the early approach group, very few patients went on to eventually require a VP shunt, so only 20%. And in our cohort of patients, 92% went on to require a VP shunt. They intervened a lot earlier, so their first intervention was at about 29 weeks gestation, and our first intervention was around 33 weeks gestation. But then what really drove it home for us were the long-term outcomes. So she looked at outcomes at 18 months using the Bayley's scores of infant development. And on both the cognitive and motor scores, the patients who had the early approach did much better. Their cognitive outcomes were much better at 18 months, and their motor outcomes were much better at 18 months, and ours were not very good. This really made us stop and think, and it was a very difficult pill to swallow for us, and certainly for a large unit that's been doing the same thing for many years, it's very, very difficult to get the team to accept that maybe we haven't been doing exactly the right thing. And certainly, of course, we needed neurosurgery to buy in, which was, again, challenging for sure. Getting the neurosurgeons even to in a room together to show them this data was challenging. But we did do it, and they still are a little bit reluctant with this, and one of the reasons for that is the pictures that Michelle showed us the other day, and the brain of a preterm baby is just like Jell-O, so the neurosurgeons really are reluctant to go in there and start cutting into that brain, putting in Ommaya reservoirs, and doing any kind of manipulation with that very vulnerable tissue. But of course, showing them this outcome data, really wasn't much that they could do to refute it. We did develop an early intervention protocol. We implemented that protocol about 2 years ago, and we're currently in the evaluation stages of our outcome data. So this was what our protocol looked like, and this is the surveillance part of the protocol, and this is a little bit small, so you can't really see what it says, but I've already told you most of this. So we would do a head ultrasound on day 3 and day 7. If there's ventricular dilatation, then the babies would be continue surveillance with biweekly ultrasounds. Once they reach that threshold of intervention, we would start the serial lumbar punctures. And if they were at one of our neighboring perinatal centers, there's 3 hospitals involved in this project. So there's Sick Kids, there's our 2 perinatal centers, Sunnybrook and Mount Sinai Hospital, where most of our preterm babies are housed. And certainly when they start to get sick or need surgical intervention, then they all come to Sick Kids. It was important for us to get buy-in from Mount Sinai and Sunnybrook Hospital because they would be the ones that would need to start this early intervention protocol with the lumbar punctures and then eventually send the kids over to us if they needed an Ommaya reservoir inserted. So this is just what the pathway looks like, and as part of the package, we have our Levine and Davies diagrams, and we keep these on all of our computer on wheels that go around the unit. So on rounds every day, we will look at the baby's head ultrasound results and plot them on the graph. We developed a ventricular reservoir tapping protocol. So in this protocol, we use a sterile technique to tap the reservoir. This is a picture of what the reservoir looks like just under the skin. So you can see there's just a little dome there and a small incision. And we just use a 25 gauge butterfly needle to tap the reservoir and remove the CSF slowly by about 2 mils per kilo per minute. And all of our nurse practitioners are the ones that do this procedure. We try to keep it to a very small group to reduce the risk of infection. And we've been doing that now for 2 years. I've got just 1 year of data to show you. I do have the more recent data, but it's not been fully correlated yet. But I can tell you that certainly the numbers now are about 94 babies, and the outcomes have not really changed much. We do have a lot of very tiny preterm babies and are born in Toronto, not at Sick Kids, we're an outborn center, but born at Mount Sinai and Sunnybrook and other places around the province. We do have a high mortality rate of about 30%, so 30% of our tiny preterm babies don't survive. Our complication rate was about 5%, which was similar to the complication rate in the pre-intervention cohort where we had VP shunts inserted as really our first line. But you can see here that 39% of the patients resolved spontaneously. So we monitored them, and they were in that high-risk zone, and they didn't actually ever require intervention, but we did monitor them very closely. 35% of the babies resolved with just serial lumbar punctures. So their ventricles came down, and they never had dilatation of the ventricles again, and hopefully we preserve some of that white matter of the brain. 8% of the patients resolved to discharge with just an Ommaya reservoir in place. So the reservoir stays in place, and eventually, if they get a VP shunt in the future, the neurosurgeons usually will leave that reservoir in because they don't want to do a needed surgical procedure of removing it. So the reservoir really just stays in place. And we reduced our VP shunt rate from 92% to 18%. So that's pretty remarkable in my opinion. I'm really excited to see what our long-term outcomes are. So our first patients are just starting to come through. We follow all our patients in our neonatal follow-up clinic at 4 months, 8 months, 12 months, 18 months and 36 months, and it's a combined clinic with neurology, so I have the pleasure of following babies in the NICU and then seeing them in the follow-up clinic as well, so that's one of the really exciting parts of being part of the neonatal neurology team is I get to see all these babies in clinic as well. And I'll just show you one of our babies here. This is Riley. She was one of the first babies that ever went through this protocol. She was born up north in Ontario in Sudbury, which is about 6 hours north of Toronto. So she needed to be transported by helicopter down to Sick Kids. She was born at 29 weeks gestation. Her mom had HELLP syndrome. It was a horrific delivery. She needed a lot of resuscitation in the delivery room. She was very unstable for the first couple of days of life, hemodynamically unstable, and she ended up having significant bilateral IVH with a periventricular hemorrhagic infarction on one side, and we were very worried about her, but we started early intervening with her, and at the first sign of ventricular dilatation, we did serial lumbar punctures for 3 days, and we were able to remove CSF during those punctures. And then she did have progressive ventricular dilatation, so she did go on to receive an Ommaya reservoir, and we tapped that reservoir for, I guess, about 3.5 weeks every day because her ventricles were not improving. And then she did actually go on to receive a VP shunt, but her outcome has been remarkable. She has been walking since 13 months of age. She's cognitively completely normal. And she had a big periventricular hemorrhagic infarction on one side and a grade 3 IVH on the other side. We are really pleased with her progress, and we're hoping that we're just going to see more and more of these success stories as we move along. So really, in conclusion, I just want to say that IVH and PHVD are certainly still very important complications of prematurity. They have implications for long-term outcome, but with close monitoring and early detection and maybe early intervention, we can start to improve the long-term outcomes of these tiny preterm babies. So here's some further reading for you, and I need to thank the teams at Sick Kids, Sunnybrook, and Mount Sinai for helping with this work. This would not have been possible without a real team effort, and sometimes when you have perinatal centers working with an outborn center, there's some conflict about how everybody does things, and people do things differently, and people don't want to change their protocols to be in line with exactly what's happening at other places. But this has really been a team effort, and all 3 centers have really believed strongly that this is the way to go, and it seems to be working out quite nicely. So hopefully I can come back and show you our outcome data after we get the 18-month outcomes for these patients.
Okay, what did you think about that presentation? Again, this was a replay from our 2021 conference in Orlando, Florida, right before the pandemic hit, and it was our last in-person event. We cannot wait to do another one conference for you, but in the meantime, we're bringing you back these amazing presentations from speakers all over the world, really, because next week we have some global perspectives on IVH prevention programs from nurses and nurse practitioners from the US and abroad. So I hope that you enjoyed this presentation with Diane and that you got some inspiration about maybe how you could streamline and standardize the care for babies in your NICU. I hope that you will follow along with all the presentations this month in our IVH Prevention and Bedside Care series here on YouTube. Go ahead and either click the link in the show notes below or scan the QR code right on this screen and you'll be taken to a page where you can enter your email address and then you can get all of the resources and the replays and reminders every single week. So go ahead and hit that like and subscribe button and I will see you in the next one.